Alright, GI bleed. Okay, so important thing for us to know is obviously how the patient is going to present. Okay, the important question is when you're suspecting a GI bleed, what is the key question you want to ask them? Before that, what kind of bleed is it, right? Upper or lower. And the key way you're going to differentiate it is melena, right, versus bright red. Now, why do you get a black color when it's an upper GI bleed? Huh?
Digestive enzymes.
Actually not. It's the acid in the stomach that breaks the blood down to produce a pigment called hematin. And the hematin is black. So it's the stomach acid that actually makes the blood black. So just the presence of this coffee ground emesis or black color tells you, hey, it's most likely from your GI source, probably stomach, right? But if it's lower, it's going to be bright red blood. Now, if your bleeding is bad enough, like a variceal bleed or a really bad gastric bleed, you're bleeding so profusely, there's no time for it to change color. You will get red blood down there too, okay? But anybody who's coming with the bleeding, our important steps in management of this patient is what? Make sure the hemodynamics are good, right? Check the blood pressure, start them on fluids, okay? So IV fluids. Apart from that, if you do suspect it's an upper GI bleed, what are we going to do? You're going to start them on PPI. Are we going to give PPI PO or IV?
IV.
Are you going to do continuous or BID? BID. They've done studies about continuous versus BID. BID is equally effective as continuous. What else are you going to do? Obviously, you're going to consult GI, right? Consult GI, and then GI typically is going to consider doing an EGD versus a colonoscopy. Let's talk about upper GI bleed. If it's an upper GI bleed, your first step is obviously EGD, right? Question is, how soon are you going to do an EGD? If it's a variceal hemorrhage, you want to do it sooner, right? If it's variceal, you want to do within 24 hours, right? If it's not, then you can do it a little later, but you still want to do an EGD, right? Now, typically, when you do an EGD, it'll tell you what the source is. If it's a gastric bleed, or is it, esophageal bleed, it'll tell you what the problem is, right? Now, important thing is identifying how of a high risk the bleed is dependent if you're seeing like a squirting vessel or you have a vessel that looks like it's about to pop, right? Sometimes you have a clean ulcer and there's no bleeding vessels or anything like that, which is less scary, right? So that's important to know to identify, right? What is the number one reason why somebody would get a gastric ulcer? Huh? Gastric ulcer is H. pylori, okay? H. pylori followed by NSAIDs, okay? Now I already covered treatment, test and treat approach of H. pylori the last time, so we're not going to go into that, right? Now, when it comes to gastric ulcer versus duodenal ulcer, which one is at risk of cancer, gastric or duodenal? Gastric has a risk of cancer, duodenal does not, okay? So gastric ulcer is when you think about possible cancer, okay? So say you do an EGD and you did see an ulcer and the ulcer is bleeding profusely, they cauterized it and the bleeding did not stop, okay? What's your next step? Yes, so the next step, if the EGD cannot control an upper GI bleed, is going to be IR guided embolization. What do you do in those patients? Because now, remember the EGD only goes till the second part of the duodenum where the ampulla of Bater is. You cannot see further past that. Colonoscopy only sees the colon. There's a large part of small intestine in the middle here, the limbo land, where you could be bleeding but you can never find the bleed. So what are you going to do? So it all depends on how bad the bleeding is. If the patient is having an intense bleed right now and is hemodynamically unstable, what you're going to do is a CTA, and the CTA will tell you where the bleed is coming from. But if the bleed is a very small trickle that you can't see it, then you will do a capsule endoscopy or a tagged red blood cell scan. Okay? This syndrome is called Heyde syndrome. Now, why does it happen though? Heyde syndrome is when you have aortic stenosis and AV malformation that's bleeding in your gut. If the patient did not have aortic stenosis, that AV malformation is not going to bleed. But something's happening. What is this tight aortic valve destroying? 1 Willebrand factor. It is breaking down 1 Willebrand factor and therefore leads to a 1 Willebrand factor deficiency, and therefore your AV malformation is bleeding. So that's why Heyde syndrome, the patient will actually bleed. Okay? So if it's just an NSAID, switch to a COX-2, move on. But you need an antiplatelet agent. If you don't need to, you can get away with one. Go with one, but lifelong PPI to protect while you're going to be on the antiplatelet. If it's a P2Y12, 5 days after the bleeding has stopped, you can resume it. Okay? And blood transfusion, pretty much for most patients, you're only going to transfuse when the hemoglobin drops below 7. Unless the patient is having acute coronary syndrome, then you will maintain it above 8. Okay? Alright, I think that's it.